So today we have a young individual who has a complete ACL tear and medial meniscus posterior horn tear in her left knee joint. We have made a separate video of the meniscus repair, and in this video I'm going to show only ACL reconstruction. So you can see that we are seeing and inspecting the joint from the anterolateral portal. I've inserted my arthroscopic probe from anteromedial portal, and there is complete ACL tear which is chronic in nature. Patient had sustained injury many months back, and this is how the chronic ACL tear looks. After debridement, we have inserted the femoral lemur from the anteromedial portal, through which I am going to drill the guide wire in the lateral femoral condyle. We do this in hyperflexed knee position. So we have drilled the guide wire in the ACL anatomical footprint over the lateral femoral condyle, and now we are going to drill with endoverton drill bit over the guide wire. So this is the drilling of the lateral femoral condyle with the endoverton drill bit. You can see the provisional length of the tunnel based on the marking on the endoverton drill bit. We have drilled the tunnel, and now we are going to remove the guide wire, and then we are going to measure the depth or the length of our femoral tunnel, which is only 30 millimeter. Our patient is short and female, so in this case we have only 30 millimeter as our length of our femoral tunnel, and because of that we are going to use adjustable loop endoverton in this case. Now I am going to reinsert the guide wire, and I am going to drill with 9 millimeter drill bit over the guide wire up to mark of 20 millimeter, because that is the length of the graft that we want in the femoral tunnel. And we are done with the femoral tunnel, and now we are going to remove the drill. This is the tunnel as seen through the anteromedial portal. You can see that it's in its anatomical location, it's in its anatomical footprint, so it's a quite good tunnel. There is no blowout. So now I have introduced the ACL tibial jig from the anteromedial portal, through which I have drilled the guide wire in the tibia. Since our patient's height is short, bones are smaller in dimension than the usual bones, and the tunnel diameter is 9 millimeter, I am going to keep my guide wire slightly posterior in order to avoid anterior blowout. So I have drilled the tibial tunnel with the 9 millimeter drill bit. Now I'm going to pass my adjustable loop endoverton from the tibial tunnel to the femoral tunnel. So as you can see, my assistant is pulling the endoverton threads, and now slowly the endo button will travel from the tibial tunnel to the femoral tunnel. Now we are going to flip the button once the mark reaches the mouth of the femoral tunnel, and we'll have visual confirmation of the flipping directly under the vision from the anteromedial portal. You can see that the endoverton is in the tunnel, still not crossed the tunnel, so we are going to pull some more till it crosses the tunnel, and then we are going to flip the button over the lateral cortex of the lateral femoral condyle. Now the button is flipped, which is confirmed by tactile sensation as well as by visual confirmation. So it's 100% flipped, and now we are going to cinch the graft from the tibial tunnel to the femoral tunnel. So now the graft will gradually travel from the tibial tunnel to the femoral tunnel. It's a quite good and strong graft for this patient. It's going to provide good stability. So we have a mark on the graft up to mark of 15 millimeter. Since the length of our graft is 8 centimeter, we want to keep 15 millimeter of graft in the femoral tunnel so that we don't fall short at the tibial end. So now completely cinching of the graft is over, and now we are going to do cyclic loading, and then we are going to fix the graft with the interference screw at the tibial end. The dimension of the screw is going to be 10 into 25. So this is the guide wire over which we are going to insert the interference screw. It's important to make sure that the guide wire is in the tunnel. And this is after the fixation of the graft. You can see that the graft is quite strong and rigid, and this is going to provide good stability to this patient, and she should be able to do all kind of sports activity in future, and there should not be any restriction whatsoever in her daily activity of living. This is how the graft looks from the anteromedial portal. It's quite anatomical and strong. So this completes the procedure. Apart from the ACL, we have done meniscus repair also in this patient. Thanks for watching this video.